Good afternoon, I'm Dr. Dumajian, August 26, 2025. Our patient presents with lower back pain. He has pain coming from his discs that are damaged at L3-4, L4-5. He has discogenic back pain. He's had chronic back pain for 2 years or more. We're going to go fix those 2 discs right now with the laser and get rid of that discogenic back pain permanently for him with a tiny little incision and minimally invasive procedure. Let me just confer with my staff. So it's right 4-5? 3-4. All right, right 3-4, left 4-5. So this side is the right side. I'll be going to the 3-4. Everyone agree? All right, now the 5-1 disc is a pseudo disc. It's somewhat of a fused disc. I'm going to go ahead and inject some local. So this side is 3-4. You all agree?
Yes, sir.
Feel free, folks, those of you that are watching, to ask questions, and I'll be happy to answer them for you. In the meantime, while we get started placing our needles, which is the first step here, why don't you tell us or show us a video on the 30 different causes of back pain. I'm Dr. R. Dumajian with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies. With trauma, can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us.
Welcome back. You can see there are 30 different causes of lower back pain. 30. And of those causes, number one is the disc. Disc pain accounts for 85% of all chronic back pain. The second most common cause of back pain is the facet joints, and that is 10% of all people with back pain. It's the main cause. And then number 3 and number 4 are going to be your SI joint and your piriformis, and that accounts for about 5% as the primary cause of back pain. Okay, we're going to repair 2 discs. I believe the L3-4, L4-5 disc, based on where I asked him, where is your back pain? He pointed right here. So I drew a box around his back pain. I tested for facet pain. He had no facet tenderness. His pain was deep and axial. That's exactly where the annular tears are for the L3-4, L4-5 disc. We've been cleaning these tears with a laser endoscopically for 20 years. We've done now more than 2,650 surgeries with laser, and our cure rate of back pain is 99.6%. That means if you take this patient with back pain that's debilitating, destroying his quality of life, you do the laser surgery on the 2 discs that we know are causing his back pain, we expect 99.6% of his back pain to be gone. Now, if he has other causes of back pain like the piriformis muscles, the SI joints, which he does, by the way, that pain down lower will not be gone because we haven't treated it. We're only treating the disc today. So we're fixing 2 discs. We're fixing the tears in the disc. This is L3-4. This is L3-4. This is L4-5. Are you having any pain? No. All right. He's comfortable not having any pain. How bad is that on a scale of 1 to 10? How high did it go?
What number?
8? I heard 8. All right. Is that where you get pain? Yes. He said, yeah. 8 out of 10, concordant. So we tested the top one. You guys see that, Jordan? Show the audience on the lateral x-ray the tear. Okay, you see the black dye? The black dye is what I injected. It should stay in the middle. You see the cotton ball in the middle? That's where it should stay. Show us where it should stay, the big circle. Yep. It should not be leaking backwards right there. All that is dye leaking through the tear along the herniation. That's where his pain's coming from. Is it better now? All right. How bad is that on a scale of 1 to 10?
8.
Another 8. Is that where you get back pain? 8 out of 10, and it's concordant. All right, my friend, when you wake up, that pain will be gone. I want you to count out loud from 1 to 100. Count out loud from 1 to 100 so I can hear you. All right, folks, we just verified that his lower back pain he's had for over 2 years now, it's debilitating. He's actually, unfortunately, lost his job as a result of that. I can't tell you any other information. But we're going to get rid of that pain today with this laser procedure. And that right there is the blood loss. 1 drop of blood. That's all he's going to have for the entire surgery is 1 drop of blood. That is this Duke laser disc repair. Bloodless, no hospital, outpatient. he's going to go home an hour after the surgery, and that pain will be gone. Let's go ahead and numb up the skin. We're going to start on the right side. We're going to fix the L3-4. Any questions from our audience?
Yes, we have about 2 questions.
Shot?
First one coming from Shirley on YouTube.
Shirley.
Shirley.
All right, Shirley on YouTube, thanks for joining our stream. What question can I answer for you?
Asking, this is really interesting. I have back pain. Does this work?
This surgery works, yes. This is for back pain. But Shirley, we have to first identify what is the cause of your back pain. Every patient has different cause of back pain, but the most common cause is the disc. We just made a 1/4-inch incision, and we're going to go in now with our dilator down the guide wire. It's a very safe surgery as long as it's done properly. We're going to give a little more numbing medicine to make it comfortable for the patient. One of the advantages of this surgery over other types of invasive spine surgery, like fusion, for example, which is also used to treat back pain, is that this surgery does not require narcotic painkillers after surgery. If you have a fusion or an invasive surgery, you're going to be taking narcotic painkillers for weeks or months after your surgery. This patient is not under general anesthesia. He's on twilight pressure. He's having twilight anesthesia, and he has no tube down his throat. This is all done with sedation, so it's much safer for the patient. We're entering the tear in the back of the disc at L3-4. Our dilator has just gone right through the tear, right where the herniation came out. You guys saw that on the x-ray. And now we're going to bring a tube. The entire surgery is done with this tiny little tube. This is called endoscopic spine surgery. The tube is 7 millimeters wide. So the whole surgery will be done through a 7 millimeter wide tube. It's bloodless. There's no hospitalization. There's no narcotics. There's no bleeding. In 20 years, we've never had a surgical complication, not a single one. No infection, no nerve damage, no spinal fluid leak, nothing. No adjacent segment disease. We are now inside the tear. Now, folks, we're not doing a discectomy. We're doing an annular debridement. What that means is we're cleaning the tear, which is where his back pain is coming from. This disc had 8 out of 10 concordant pain. That means it's a pain he gets every day. He was able to confirm that because he's awake. He's asleep now, but he was awake during the discogram. Any questions?
Yes, this next question is coming from Lanu on YouTube.
Before we do that, let me show you guys the endoscope and the entire rig. We've been using the same rig for 20 years. It has a rigid endoscopic shaft through which we can put surgical instruments like the laser or grabbers such as pituitary rongeur. We have a light source at the end. The actual light source is here, and it uses fiber optics to push light all the way through to the end so we can see what we're doing. And we have a little rod lens system that allows the image at the tip to be projected onto the camera. This is a high definition camera. It allows us to see what we're doing. The entire surgery is done with a 1 millimeter laser fiber, 1 millimeter. Super precise, super safe. Never had a complication in 20 years with using this laser fiber. So here we go. We're going down the rabbit hole. There is the disc. There is the herniation. It's blue. We stained it a blue color. I'll use the grabber first. Now you see that pink right there? That pink right there is the inflammation. And I'm going to show you a video right now that explains how that inflammation is the cause of the back pain. Go ahead, Henry. Let's show people how a disc herniation, annular tear, causes back pain through inflammation.
Disc injuries start with an annular tear, damaged nucleus. Pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see from our video that back pain, which the most common source is the disc. And 85% of people with chronic debilitating back pain, 85% of them, their back pain is coming from injured discs. We call those injured discs herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, slip disc, bulging disc, degenerated disc. All of those names mean the same thing. It's a tear in the capsule or wall of the disc called the annular tear, which then lets this blue stuff, you see the blue stuff here? That is the herniation stuck inside the tear. And that's what I'm removing. It's that herniation within the tear in the back of the disc, not the front, not the side, but the back specifically, that causes back pain. All right, let's show the audience how we use this 1 millimeter laser fiber and the endoscope to find the tear where the herniation is and remove the herniation and debride the annular tear. This is a novel procedure. I invented it. I am the inventor of this technique. The first to do it 20 years ago. It's been peer-reviewed and published almost 10 times in the medical literature at national meetings where I've presented it to neurosurgeons. It's been peer-reviewed and basically published in medical journals and at national meetings. So this is a proven technique that works. Everything we use is FDA approved. There is not a single non-FDA approved drug device that we use during the surgery. So it's completely FDA compliant and always has been.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4 inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see the herniation here, the blue stuff and white stuff right there that I'm zapping away with the laser. It seems to be disappearing. What's happening is the laser is releasing it from the scar tissue, holding it down to the disc, and it's floating up and out the tube. And if you look outside the patient's body at the end of surgery, you're going to see all these little pieces of herniation. The reason they're stained blue is we put a special blue dye that only stains herniations. It only stains herniations. And the blue indicates not just that it's a herniation, but it's also it's acidic. That's ACIDIC, acidic. Acidic herniation, which means it's a degenerated herniation. So remember degenerated disc? Well, what that means is that the disc is degenerated and collapsed. You get first degeneration of the herniation along with inflammation, and that's what causes the degeneration. All right, this is the tear right here. You're seeing it left to right. We're looking down the tube. Remember, I showed you guys this tube. It's 7 millimeters wide, and look how precise the laser is. That glass fiber is 1 millimeter wide, 1 millimeter wide, and it's delivering laser energy from a laser machine here at the patient's feet. There's some more inflammatory tissue right there. I just zapped it with the laser. That's where his pain is coming from. So why does inflammation cause pain? The answer is nerve fibers. You see, inflammation, when it's chronic, meaning lasting more than a few weeks, it starts to bring in new nerves and new blood vessels into the area of inflammation. In this case, it would be the annular tear and the disc. So over time, as people suffer with discogenic back pain from inflammation going on within the tear, they're making more and more scar tissue, more and more bone spur, more and more nerve fibers that are painful nerve fibers. So the key with these patients is when you have a bulging disc or a herniated disc, the key is to fix it right away before it lays down more scar tissue and becomes harder to fix. My recommendation, if you have back pain or neck pain that's been going on for more than, say, a month, and you have been determined to have discogenic pain, which is pain coming from a damaged disc, you should get the Duke laser disc repair done sooner than later. Don't put it off, because your disc will just degenerate and collapse over time if you don't get the treatment done. We're advocating earlier treatment for improved quality of life and better results for the patient. All right, any questions?
Yes, we have a few questions. This next one coming from Lanu on YouTube asking, what symptoms does this patient have? Any numbness?
This patient has primarily back pain at L3-4, L4-5. It's so bad that he's unable to function normally. We call that back pain spinal instability. Spinal instability was first defined in the medical literature through a peer review process in PubMed by two doctors, Dr. White and Dr. Punjabi. And Doctors White and Punjabi define spinal instability as patients who develop symptoms of back pain or neurological deficits, which is your weakness, numbness, tingling, or pain down the leg. So neurological compromise or back pain that's debilitating and pain very severe with normal activities. So they have normal activities like walking, standing, working, and they have horrible back pain or leg symptoms of weakness, numbness, tingling, or pain. There's 4 leg symptoms and back pain. Any of those indicate spinal instability. You don't have to have both leg symptoms and back pain. You need leg symptoms or back pain or both. This patient has debilitating mechanical back pain, and it's discogenic, meaning it's coming from the discs. I know that for a fact, and we just verified that with the discogram. That's his primary symptom. Just about done. There's the end of the tear right there. You can see the blue stuff is the herniation. And all this white stuff is scar tissue, the really, really white stuff. That comes from chronic inflammation. In other words, he tried to get this fixed before, but his insurance carrier wouldn't cover it. So they put it off, and as a result, he has more scar tissue, more pain, and more suffering. Huh? How's he doing, by the way? Good? All right, we're just about done. Yeah, we're gonna do, look at this piece of herniation right here. We're gonna do this side, folks, and then I'm gonna step over to the other side, because the tear on the L3-4 was on the right side, but the tear that I'm worried about at L4-5 is on the left side. And he has bilateral symptoms. All right, grab her. I'm gonna grab out that piece of herniation. We got about 2 minutes left on this disc, and we're gonna move to the other disc and fix that one next. Look at that piece of herniation that was stuck in there. You guys see that?
Yes, we do.
Let's show the audience. Turn the light on. All right, I just grabbed it out. You guys see this here?
Yes, we do.
Yep, thanks, Luis. It's a full centimeter long. That just gives you an idea of what it looks like. And if you look over here, right here, there's tons of pieces of herniation all over the place. I don't know if you can see these, Henry. But
yes, we can.
like all these little pieces of herniation that they all came out of this tube right here. As soon as I release them with the laser, they come up and out. They overflow out into the bag. We don't really keep track of them, but I would say the average patient will have about 30 pieces of herniation pieces of herniation, we call them fragments, in each disc herniation. So if you say the patient has an L4-5 disc herniation, typically we'll find about 30 pieces of herniation in that L4-5 disc. Where's my pedal? Okay. Any questions from the audience?
Yes, this next question is coming from Mike on YouTube,
Hi, Mike. Welcome to our live stream.
saying, Dr. Duke, I have 3 annular fissures. I have lower back pain and numb burning my painful feet. I sent my MRI in. Can you please review? I cannot sleep with the pain.
Absolutely, we will review it. I'm so sorry you're suffering. Duke Spine Institute hopefully can help you. But with the burning feet, I would want to know, do you have a nerve test done? I want to know if you have any peripheral neuropathy. That would be on the nerve test. They would say sensory motor nerve damage, small nerve fiber damage. So if you have neuropathy on top of the pinched nerves from your back, that could be contributing to your symptoms. And it's important to know that ahead of time, because we want to know how much of your symptoms will go away with treatment, like surgical treatment, versus not go away. So if you have peripheral neuropathy, that will cause burning in the feet, numbness in the feet, typically the bottom of the feet. You just need a nerve test to find out if you have peripheral neuropathy. Hopefully you do not. The most common cause of peripheral neuropathy is diabetes. All right, so far everything's going well. We're just about done. This was a massive tear at L3-4 with all this blue stuff, herniation, stuck in the tear. Remember the entire tear, the front tears and side tears do not cause any symptoms. It's only the back tear, the tear in the posterior. And that's because of the innervation of the disc. The disc is innervated by different types of nerve fibers, but the innervation right here in this part of the disc is always somatic afferent, and it's the sinovertebral nerve that brings these pain signals up to your primary somatosensory cortex, which is how your brain perceives this horrible, localized, severe, sharp pain in your back from a disc problem. Thank you. All right, we're pretty much done here. I'm going to move to the next. You can see the epidural fat. You can see some fiber, but this is the end of the disc right here. This is the end of the herniation. We've cleaned out probably about 80% of it, and we never get 100. We don't need to get 100. We need about 50% to get a great result. And in his case, we've gotten about 80% of the tear. So everything has gone very, very well for him so far. And we're going to leave this disc and move on to the next disc. Any questions before we move on to the next disc?
Yes, we have a question coming from Lanu once more on YouTube. Oh, and we just got another question, but asking
Before you ask the question, let me just show you guys. We are now outside the disc, just looking at the outside of that disc from the right side at L3-4. And you can see we've debrided the tear, got rid of the herniation that was stuck in there. This will now seal itself. The patient's body will seal it over. You don't need metal, you don't need plastic, you don't need artificial discs. We did not remove the disc. We did not do a discectomy. All we did was remove the part of the herniation stuck in the tear. We call that a herniectomy and an annular debridement. And that's what's unique about this procedure. That's why it works to cure back pain. All right, let's take the question.
Lanu asking, Henry, the girl that replaced you during your vacation, where did she go?
Lily.
Lily. She is in Duke's Bay right now. Just
She's here.
Yeah, she's here. She's still in the office, and so
We didn't fire her.
no, but she's doing other work, and she was just able to cover me during that time. So
Yeah, look at that. Yeah, Lily is a phenomenal employee. She bleeds red and blue, red, white, and blue, like the rest of us. And gold, I should say. All right, I'm going to take this tube out, and what we're left with is basically a tiny little cut that's a 1/4 inch. I'm going to put a staple in that cut, and there's a piece of herniation right there, by the way. You guys
We can
see
see it?
that? Yeah. a little piece there. There's another piece there. They're kind of all over the place. And that's fine as long as they're not in the disc. I'm happy because when they're in the disc, that's where they're causing pain. There's the cut right there, folks, 1/4 inch. And we're going to put these staples in. We'll get them off tomorrow in the morning when the patient comes in for a checkup. And then we're going to switch them out for just a Band-Aid, basically. So that's the right side. I'm going to switch sides with Luis. He's going to come over here. And I'm going to go to the left side and do the L4-5 on the left. Because that's where the tear is. At 4-5, it's on the left side. That's the tear causing pain. All right, you have more questions?
Yes, this next one is coming from George on YouTube, asking, when the tear is central, how you debride it? How do you debride it since you entered the disc transforaminal?
George, that's a great question. Thanks for asking. So central tears in the back of the disc are never just in the center, and if they are, they don't cause symptoms because that's where the posterior longitudinal ligament runs, right down the center of the back of the disc. So really the places where the disc is the weakest and most prone to injury is the back sides, either left or right, because the PLL supports and bolsters the center of the disc, prevents herniation really from coming there. But a lot of people get broad-based disc herniations where we don't have to just treat the center, we treat the side because that's where the pain is. We've been doing it for 20 years. We've never had a single failure to eliminate the back pain from the disc. All right, we just made another incision. This will be another 1/4 inch incision. I'm going to remove the needle. We don't need it anymore. Shot. I'm going to make sure the guide wire is in good position. It is. The guide wire will guide my next instrument called the dilator. The dilator is like a metal pencil. It's going to slide right down the guide wire. Very safe. I did not invent this. This was developed by surgeons much smarter than me years ago. This whole concept of guide wires and dilators. Dr. Seldinger? Dr. Berndes says that Dr. Seldinger is the one who invented this.
It's called the Seldinger technique.
Seldinger technique. I didn't know that. Central line. So first used in central lines and now applied to orthopedics. But it's an established technique. This whole concept of dilators and guide wires. All right, heading in. You can see the dilator tip is just outside the foramen. Here we go. Yeah, George, great question, but for some reason it just works. You know, this debriding the tear from the side foraminally, transforaminally, just works every single time. And I can actually get all the way up to the midline, to the center of the disc. And if I have a big tear that goes on both sides, from the center left, center right, and the patient has symptoms on both sides, I'll just go on both sides with the laser and clean it on both sides. All right, we are inside the tear. Yes, good. Now I'm going to bring in my tube, once again, 7 millimeter tubular retractor. I'm going to drive it into the tear that we're going to be debriding. And yeah, that's it. We're in. So we're not doing a discectomy, folks. We're just doing an annular debridement. We're getting rid of the herniation stuck within the back tear, the tear in the back wall, which happens to be about 2 centimeters thick. The annulus fibrosus is around 2 centimeters thick in this area, and it's torn and it has herniation stuck inside it. That's where all of his back pain and leg symptoms are coming from. That's why we do the surgery. It works. All right. Any other questions?
Next question is coming from Mike once more on YouTube.
Mike?
Saying, I believe this is a comment, but as saying, I have lumbar spinal stenosis at L3-L4, moderate. My blood sugar is under 99. I would like to get the DLDR next Tuesday if you feel that I need it. My MRI is 1 month old.
Oh, I would love for you to come next Tuesday, my friend. Where do you live? Hopefully you're nearby. I don't know if you live in Florida, but I certainly can do an MRI review with you tomorrow. Just call Natalie, 321-787-8255. 775-1299. 321-775-1299. Henry will put that phone number there. But that's our MRI review line, and Natalie will take your call and hopefully put you on for tomorrow. The other way you can get in to see me tomorrow is come into my office in the morning here in our office, and I'll be happy to see you.
Next question is coming from Scott on LinkedIn.
By the way, I want to point something out while we're here, okay? You guys see that little edge of the tube right there?
Yes, we do.
Hey, that's the end of the tube. We are inside the annular tear, right inside the herniation and tear. I want to make a point. I stuck the grabber down here and I grab all the pieces of herniation I could, but I could not get these out. You guys see that? They're stuck down, scarred down. That's why you must have a laser. Laser is absolutely necessary to do the surgery. You cannot do it with the grabbers. A lot of people say to me, why can't you just use the grabbers like other doctors? The answer is it doesn't work. It doesn't pull those pieces of herniation out. The laser does, but those grabbers do not. That's why I started using the laser in the first place when I started doing endoscopic transforaminal surgery 20 years ago. My goal was to get the pressure off the nerve root to treat leg pain. Patients had back pain and leg pain, but I didn't plan to get rid of their back pain. I only planned to get rid of their leg pain. But I couldn't get enough of the herniation pieces out with the grabbers. So I decided to bring the laser in and start using a laser to help remove the herniation. And lo and behold, the patients woke up pain-free and their back pain was 100% gone. And I did the same thing in the neck when I was doing cervical disc. And basically, long story short, it turns out the laser's essential for getting rid of back pain and essential for getting rid of neck pain from the disc when you have discogenic back or neck pain. I got 5 minutes. 5 minutes left. Dr. Berndes is wanting to know, for the patient's safety and anesthesia stuff, how much longer the surgery will be. I expect 5 minutes. Let's see what happens, but this is a big herniation here at L4-5. Any other questions?
Yes, we have a few more. Next one coming from Scott on LinkedIn.
Sure.
Asking, good afternoon all, long time no chat. What if the converse was true? If your imaging shows eye-popping diagnosis, but you have 0 symptoms, do nothing? P.S. Pro business tip: pair up with a few health insurances on YouTube, and then interview them, or vice versa.
I like that tip. First of all, thanks. So great question. I love the question. That's an amazing, awesome question. I hope everybody understood it. But what he's saying is quite interesting. So I'm going to break down the question because it needs to be broken down to understand the nuance. So first of all, he said, this viewer said, all right, like, we get that, you know, maybe you have a small herniation or disc bulge that everybody else says is tiny, don't do anything, leave it alone. But Dr. Duke, you're saying if that thing's causing pain, then you should treat it, right? And the answer is yes, I do. I say that because treating it's how you get rid of the pain. But he's saying, well, what if you have a gigantic herniation, but the patient has no symptoms? And the answer is you don't treat it. You're asking me what I recommend. I recommend not treating it. But I want you to understand there's a caveat. The caveat is this. If that patient says to me, Dr. Duke, I got no back pain, I got no leg symptoms, I'm totally normal, and I live 100% normal life. I run, I exercise, I have a normal life, no symptoms. All right, if that's true, and I do a physical examination, here's the key, and I find that you have no weakness in your legs, no numbness in your legs, no reflex changes, no straight leg raise, all signs of nerve root entrapment. If I find that there are no physical exam findings that are related to your problem, then I agree. No symptoms, no signs or physical exam findings, no treatment. Okay? Period. But if you were to tell me I'm fine, I have no symptoms until I start to go for a jog, and after 500 feet I get horrible back and leg pain, then I would say you do have symptoms. You're just avoiding activities that make the symptoms worse. So if you have a huge herniation, 0 symptoms, and you do everything you want to do in life without restrictions or pain, and you have a normal physical examination, then you should not treat that massive herniation. Okay? But I would argue that you're not going to have no symptoms and no signs, that we're actually going to find that there is weakness in your legs. You just didn't know it. We see that all the time. We have patients all the time. I got 4 minutes, and the patients come to us and say, I have no leg symptoms at all, just back pain. And then we do an exam on their legs, and lo and behold, they got foot drop, or they're starting to get foot drop. They just compensated for it, and they didn't even know they had it because they've been lifting their leg higher when they're walking. So they didn't even know they had it. All right, any other questions?
Yes, this next question is coming from Poodle Dog on YouTube,
Poodle Dog.
asking, my question is, what are you using on the patient's anesthesia or propofol, and how long is the surgery, may I ask?
Great question. So the surgery is typically about 20 minutes per disc, and Dr. Berndes is using propofol and fentanyl, and sometimes he adds in a little, what? Oh yeah, we also use Versed, so that patients don't remember anything. We don't want them to have bad memories. So fentanyl for pain, Versed for memory, and propofol for just sleeping, maintenance. And then sometimes he uses ketamine for patients who just are set up chemically different and they don't respond as well to the propofol, and they need a little extra. We're just about done. We're going to be done in 10 seconds. Don't change it. I guess you already spiked it, right? So go ahead and change it. That's fine. Thank you. Good job. Yeah, so propofol, fentanyl, Versed, sometimes ketamine. I hope that answers. Any other questions? What is that noise? Okay.
No current questions, so we do have a comment coming from Mike, once more on YouTube,
Yes, Mike.
saying, I talked to about my cervical last week. I sent in my lumbar MRI with cervical. I was told you would not review my lumbar, only cervical at this time. I live in Florida. I have lower back pain for over 15 years.
Oh, Mike, we will review your lumbar. Absolutely. The thing about it is everybody gets one free MRI review, which you did, I think, your cervical, and then you got to pay for the lumbar. But it's still pretty cheap. It's going to be a lot more convenient just to pay and do the lumbar. The other option is if you've signed up already for your cervical surgery, then we do the lumbar no charge. So we don't do unlimited free MRIs. If I did that, I would probably never do anything but MRI reviews all day long, and we go out of business like overnight. So we can't just do free services all the time. We actually have to charge a little bit, but everybody gets one free MRI. All right, we're done. Henry, why don't you share with our audience the Duke laser disc repair and how it compares to other treatments?
Of course.
Guys, suction is not working.
CD on, please.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain.
Hi, I'm Dr. Duke Machen. We've just completed our free MRI review with Duke Spine Institute, and I've diagnosed you with discogenic back pain. The spine is made up of many bones and joints. It's the joints that are actually the source of back pain. The disc is by far the most common source of back pain, as is in your case. It is the cause of your back pain, the primary cause. In your case, the primary cause of your back pain is an injury to a disc in your lower back that is causing
causing inflammation and hence back pain from the inflammation. Inflammation is the source of all pain in the body, whether it's a broken bone, whether it's an injured joint or an arthritic knee. Pain comes from inflammation. Inflammation is a process where your body is trying to repair a damaged joint, and it creates swelling, tenderness, heat, and pain. The pain you're experiencing in your lower back is primarily coming from a small tear located within the back of the wall of a disc. Now, I may have diagnosed you with more than one disc as the source of your pain, and each of those discs cause pain through the same mechanism. As you see in our video, trauma causes a tear in the back wall of the disc called a posterior annular tear. At the same time, it fragments the nuclear material just inside the wall, and over time, after the injury, you, through activities, push out small fragments of disc herniation into the tear, which then causes cycles of inflammation and pain. And that's why you're experiencing your lower back pain. At some point, your back pain could become permanent and not just reside in your back and not ever leave. But typically, people go through a phase where the back pain is cyclical, where it comes and goes, and activities are generally the cause of the back pain flare-ups. In your case, we can fix your back pain by performing a state-of-the-art procedure only available here at Duke Spine Institute. This is a minimally invasive arthroscopic procedure performed with a laser. This procedure is called the Duke Laser Disc Repair. We've been performing the Duke Laser Disc Repair since 2006 here at the Duke Spine Institute. To date, we've had 0 complications. The Duke Laser Disc Repair is the safest, most effective treatment for back pain coming from an injured disc like yours. We're recommending you consider the Duke Laser Disc Repair as your primary and main treatment option to get rid of your back pain quickly and permanently with minimal impact on your life. Recovery from Duke Laser Disc Repair is just 1 hour. You're going to go back to your hotel after the surgery. You'll spend the night in your hotel recovering, and then in the morning you'll come in for a quick checkup. The checkup usually takes about 30 minutes, and then you can go back home after the checkup. Alternative treatments to the Duke Laser Disc Repair are far more invasive, and the outcome of those treatments is far more uncertain. There are many surgeons offering treatments such as laminectomy, discectomy, spinal fusion, disc replacement. Other treatments include injecting materials into your spine, such as epidural steroid injection, or injecting material into the disc itself that will supposedly repair the disc. I can tell you, we used to perform these treatments and they don't work. They either don't work or they don't last. And if they do work, they work temporarily, and they're associated with a high complication rate. For example, laminectomy is highly invasive. There's destruction of muscle and bone and ligament in your spine. When the surgeon removes the bones and ligaments out of your spine, it creates tremendous amount of scar tissue and instability of the spine. Patients frequently come back needing spinal fusion. Patients with laminectomy are often in chronic back pain for the rest of their life, going in and out of pain management, on and off of pain pills, and in and out of physical therapy. They frequently require multiple surgeries in order to feel some type of pain relief. An alternative treatment is called a microdiscectomy. Microdiscectomy is another invasive procedure where the surgeon is removing bones and ligaments to get down to a herniated disc that's pinching a nerve root. Microdiscectomy is not a treatment for back pain. It is only recommended for leg weakness, leg numbness, and leg pain. Microdiscectomy does not fix back pain and should be avoided if you have back pain. Laminectomy does not fix back pain and should be avoided if you have back pain. Spinal fusion is a treatment for back pain. The surgeon must either remove or fuse the disc using hardware such as screws, rods, and bone graft, including cadaver bone graft. You're receiving biological bone graft from a dead person. That's what's allowing your bones to fuse together. Now, these spinal fusions can be quite effective at eliminating discogenic back pain, which is the type of back pain that you have. However, they carry a very high risk of complications. Complications such as blood clots in your legs, which could migrate to your lung and kill you in a process called pulmonary embolism. They also have a high risk of infection. Every patient that does a fusion requires postoperative narcotic opioid pain medication. Opioids are known to be dangerous, addictive, and have a high potential for abuse. You don't want to start opioid painkillers if you can avoid it. With the Duke Laser Disc Repair procedure that we have recommended for you,
you, there is no need for postoperative opioids. Our patients are treated with a small 7-millimeter incision. That incision has minimal to no bleeding, and it heals within a few days. There is no need for narcotic painkillers. If you have the Duke laser disc repair, we can fix the back pain within 3 days coming from your damaged disc. We recommend you talk to our schedulers. They'll answer any additional questions you have. We'd love to see you here at Duke Spine Institute and provide you with the highest quality, most advanced treatment in the world that gives you the safest, most effective outcome in the world that lasts a lifetime. Thank